Hi, welcome to the OMFS Survival Guide session on dental trauma. Today we will be talking about different dental trauma cases that might present to A&E, considerations around those cases, and also how you might manage those cases when they come in and when they present to you. My name is Mairead. I'm a second degree student at the University of Manchester, and I'll be talking you through the slides today. There's a contact email address at the very end of the session, so if you've got any questions, please don't hesitate to send them on and we'll be more than happy to answer any questions that you've got. The aims and objectives of today's session are to help you to gain an understanding of the management of dental trauma in a hospital setting. This can be a little bit different to the management of dental trauma in a dental practice setting or in a dental chair, so we'll also talk through some of those considerations. We want you to be familiar with the most recent dental trauma guidelines, and these have somewhat changed in the last few years. We want you to be able to apply the theoretical knowledge of these guidelines to dental trauma cases in both adult patients and child patients. And we want you to be aware of appropriate post-injury advice and treatment. This is quite important because in a hospital setting it can be a little bit difficult to have kind of a long-term follow-up procedure in place, but it is worth knowing what you should be advising patients and where you should be advising them to go. First case, you are the overnight SHO on call when A&E bleep you to come and see a patient. The history that you get is that the patient's had a bang to the mouth and their front teeth are sticking out. When you ask for some further history, they tell you it's a 28-year-old male who's taken a hockey stick to the face whilst playing a match. And this is actually quite a common scenario. So when you're given a history like this, the first thing that it's really important to do is to get a little bit more information. The really important and pressing things to know about are the patient's head injury status and whether or not they've got a C-spine injury. If you think about a dental trauma injury, it's injury to the face, and so by definition, they've got a head injury. In a hospital setting, we tend to use this to refer to an intracranial injury, really, and it's really important that that's been excluded before we provide any treatment or potentially discharge a patient who's got an intracranial injury that might need more urgent and more pressing intervention. Similarly, with the C-spine, you want to be sure that they haven't done any lasting damage to their neck or any damage that might potentially cause them trouble down the line. And again, the dental trauma would tend to be secondary to these things, so it's really important that you're sure that these have been excluded in the first instance. Another thing worth asking about over the phone is how his bite feels. It gives you an idea of if he's got a changed occlusion, and this might prompt a few other thoughts, which we'll talk about in a few slides' time. You want to know if he's got any other injuries. Very often when you get a referral, the only information you get is the information that the referring clinician thinks is pertinent to you. But it's really important to know if they've got any other injuries, if they've got any more pressing injuries, if they're going to be admitted under another team, or if the only input that they need is from Max Fax. What you really don't want is to go and see a patient and treat their dental injury and discharge them home when they've got any other injuries, a broken arm or anything that might need surgical intervention or might need admission. It's really important to know those and to be able to kind of work your way around those and provide an appropriate treatment and also at an appropriate time. You need to know their medical history. If you're going to provide treatment to them, you need to know that anyway, but it's worth knowing whether that's a consideration in how they've injured themselves, and it's worth knowing whether or not that's going to affect your treatment plan. And we'll talk about that later in the session as well. And finally, you want to know the social history. You want to know the background. You want to know how their injuries happened. You want to know if they're a smoker because that will affect their healing. And you want to know if they're intoxicated at the moment because that again will have implications for how your treatment is managed. So for our specific case, this gentleman has been cleared of head injuries by accident and emergency. They've told you there was no indication for a head CT because they've had no loss of consciousness, nausea or vomiting. If you want to know more about the indications for a head CT, there is very clear and nice guidance on this, which you can look up, and it gives a very detailed breakdown of when a head injury CT is or isn't required. His observations are all within normal limits, but he does say that his bite feels off. He's also got a laceration of his lip, which is oozing a little bit, and he's got a medical history of asthma. For this, he uses steroid inhalers every day, and he also takes salbutamol as needed. This patient has never smoked and only consumes alcohol on social occasions. He's obviously not currently intoxicated, as he was well, we would hope not, as he was playing hockey at the time of the incident. But again, that's always worth clarifying. These are the clinical photographs from this case. It's worth, when you're describing these in an exam type situation, say for MFDS, to describe this as an occlusal or a frontal photograph of the patient with cheek retractors in position. But for clinical purposes, it tells you quite a lot of the information that you need to know. So as you can see, this chap has got palatally luxated central incisors. Also worth noting that he's missing his lateral incisors, not in an avulsed sense, but in they look as if they're either congenitally absent or previously extracted. It's very important in a case like this to exclude any other fractures, and hearing the bite feels off phrase should really prompt you to consider facial bone fractures until you've gained more information. So it's really important that you exclude any Laffour type fractures. It's also important to exclude an alveolar fracture, and it's important to exclude a mandibular fracture because he's saying his occlusion is off. It's really important to examine him fully, as well as to get appropriate radiographs and investigations, which we'll talk about shortly, in order to make sure that you're not missing any injuries. It's really important to do a really complete intraoral and extraoral examination because it's very easy to miss something in these patients. When a patient comes in with extensive dentoalveolar trauma, it can be quite bloody and quite daunting for the patient. And something that I often find it's quite nice to do is to just take the time to clean them up a little bit. It helps you to assess their injuries more fully. If you need to numb them up to do so, that's fine. It helps you to assess their injuries more fully, and it also helps them to feel a sense of reassurance that you know what you're doing and that you're not going to miss anything. Another really, really important thing is to make sure that any missing teeth or missing pieces of teeth are accounted for, which we'll again touch on later in the session. So it's time to consider what other investigations you would like. In an ideal world, for a patient with dental trauma, you would get some periapical radiographs of the traumatized teeth and a maxillary occlusal radiograph. This is unfortunately not particularly realistic in a hospital setting or in an A&E setting. They won't have intraoral radiographs readily available to them, so your next best option is to take an OPT. This won't show you the teeth in any great detail, but it may help you to exclude any root fractures, any bony fractures, and it will certainly help you to exclude any mandibular fractures, but they're not as good as intraorals. Another thing is that it's really important to always review the whole image. So if you're looking at traumatized central incisors, don't forget to look at the condyles, for example, as there may be a condyle fracture that you haven't noticed. It's also really important that you report on the whole OPT. So if they've got periapical pathology associated with a lower 6, you don't necessarily have to treat that in A&E, but you should make the patient aware of it so that they can act on it down the line. Again, in hospital, you're very unlikely to have dental special tests available to you like ethyl chloride or electronic pulp tests. But in a gold standard type scenario, you would do those before numbing the patient up so that you could assess the vitality of the teeth at the time of the trauma. You might need other facial bones imaging as indicated or prompted by clinical findings. You might need some soft tissue radiographs if there are fragments of teeth missing. If they've had a CT that includes their facial bones as part of a trauma series, you possibly don't need any further imaging. It's important in that instance to try and minimize the radiation to the patient, and they might not even need an OPT. Just be careful to review the CT yourself as best you can, especially because dental alveolar injuries can often actually go unreported on these CTs. Bloods might be indicated, but this is case dependent. For example, a coag might be useful in an anticoagulated or warfarinized patient, or in a patient where you suspect they've got infection with a delayed presentation. You might get a full blood count and a CRP to look at their inflammatory markers and give you a measure of their systemic well-being. So the OPT, when you get it, shows malpositioned central incisors, but no other traumatic injuries. So how are we going to treat this case? Well, we're going to put some local anaesthetic in. These injuries are sore, and patients tend to be in a lot of discomfort because, as with the chap in this case, he can't bite his teeth together. He's kind of hanging his mouth open a bit in order to try and stay comfortable. So, nicest thing to do in the first instance is to numb them up. For the lip laceration, it's also worth infiltrating around there because it's going to need some sutures. You should debride the wounds and around the teeth with saline to make sure everything's as clean as possible. You want to reposition the teeth with firm digital pressure. If you haven't done this before, it can feel really strange, and very often with the posterior luxation of teeth, it takes quite a push to get them to snap back forward into position. This is because they often come with an alveolar fracture component. If you think about it, to displace the teeth backwards, the buccal cortex must be in some way traumatized as well. So it takes a firm bit of pressure to reposition them, but they do often then snap back into their original position. Once they've been repositioned, check the patient's occlusion. If it's not right, it's unlikely that the position of the teeth is right. So it helps you to kind of verify, and they will often be able to tell you if it feels normal or if it feels early. If you happen to be in a unit where you've got some articulating paper available to you, then you might be able to check with that, but very often, again, in an A&E setting, you won't have that. And then you should apply a semi-rigid trauma splint, which I'll go through in a little bit more detail just now. It's really worth pointing out that this can be really tricky on your own, particularly overnight in ED, where you're trying your best to maintain moisture control and to help the patient out whilst having four hands trying to put everything together. So this can be really quite challenging to do, but again, it's the optimal treatment for these patients. So we do have to do our best to try and place a trauma splint as best we can for these patients. A little more detail on the splinting. So it should be a semi-rigid splint. You don't want it to be fully rigid, as that lends to ankylosis a little bit more readily, but you don't want it to be movable either. It needs to be about 0.4 millimeter steel wire splint, and in most units you should have this available to you, either in your MaxFax office or somewhere within the A&E department, depending on where you work. You should include 2 teeth on either side, and this minimizes any kind of rotation around the wire and helps it to, again, achieve that semi-rigid goal. You should suture any soft tissue lacerations. This might be easiest to do first, because if you think about the moisture control that you want to try and gain, if you've got a lip laceration bleeding down on top of you every time, then it's probably easiest to suture the soft tissue laceration first and stop that bleeding to even just help maintain your moisture control, and it's more comfortable for the patient. You should advise them about a strictly soft diet, and this is really important in terms of the prognosis of the teeth. And you should advise them to see their dentist as soon as possible. This can often be quite tricky, and you may need to wind up telling them to call NHS 111 to try and get an emergency dental appointment, or to try and call around and find a dentist as soon as they can for follow-up. When we apply a splint, we usually can't get them back to take it off, but it is really important that they do have that follow-up, or else you've just put something in that's kind of a reservoir for infection. So really important that they get that appropriate follow-up and that you enforce the importance of that before they leave the department. This is a really nice paper that was published in the Journal of the Irish Dental Association a few years ago. And it gives the different options for applying a trauma splint. So if you find yourself stuck, it gives some really useful little tips and tricks of how best to do it. Obviously in their photos they've used the kind of optimal way of managing it, but as you can see there's kind of a few different options that they've given you there for managing a trauma splint. Another option is a pull down splint, and this can be particularly useful where there aren't particularly good adjacent teeth to splint to. Or in certain circumstances, which again we'll discuss later in the session. As a general rule for dental luxation and injuries, you'll give some local, you'll wash out the site of the injury, you'll reposition the teeth, and the exception to this is with intrusion injuries, which we'll talk about. And then your follow-up should be dictated by the injury-specific dental traumatology guidelines. So when they're reviewed, what type of special tests they have, when they have radiographs, and how long the splint should stay on. are all considerations, and these are all outlined for each individual injury in the dental traumatology guidelines. So if you're unsure, those are the best place to look, and there are some resources on the App Store, for example, the Tooth SOS app, which can help you to access that more quickly. Again, the dental traumatology guidelines are really very much the gold standard in the management of dental injuries. Although in an A&E setting, it's not always possible to achieve the optimal treatment for these teeth. If we can get as close as possible, then we're doing right by the patient. I've just included a picture here of the various different dental trauma diagnoses. It's worth knowing them and being able to obviously name them so that you can look up the appropriate treatment if you're in any way unsure. There's kind of a little mind map here of the diagnostic criteria for each type of injury. So now we move on to case 2. The scenario in case 2 is that, again, you are the on-call SHO and you're called to A&E to see a patient. The patient is an 8-year-old female who had a seizure and knocked her tooth in. She's also chipped the next tooth over, and an adjacent loose baby tooth has fallen out. And this is the only initial information that you're given. So you're asking for some further details, and they tell you that this patient has known epilepsy and that she's taking lamotrigine. She doesn't have any known drug allergies, and she's up to date with her vaccinations. This is important as consideration of her tetanus status is quite an important consideration, particularly if this happened outdoors. It's important that they've got tetanus cover. She doesn't have a regular dentist, and she's come into the department today with her mum and her younger brother. Some other things that are worth considering are the timing of your presentation, particularly in all children. It's important to note if it's a timely presentation, if it's an appropriate presentation, and if the history is appropriate with the findings. In every child patient, you should consider the possibility of a non-accidental injury. In this instance, as the child has known epilepsy, has presented in a timely fashion, and her injury, as you'll see, is consistent with the mechanism of injury that they've described, this is unlikely to be the case. But as I said, it's something that you should consider in every patient. So they tell you her observations over the phone, and she's got a patent airway. She's speaking in full sentences with an SpO2 of 98%. She's got a respiratory rate of 22 and a heart rate of 90. At an initial glance, you might think that these are abnormal because most of us are familiar with normal obs for adults. However, this is an 8-year-old child, so she's not tachypneic and she's not tachycardic. These are within normal limits for a child of that age. You wouldn't really be expected to know the normal values for the different child age ranges off the top of your head, but this is something that you can quite easily look up if you've got any concerns or if any of the numbers look abnormal to you. Her GCS is 15 and she's sleepy but rousable when you see her. This sleepiness may be post-ictal following her seizure, but again, it's important to ask the appropriate questions and exclude a head injury. And her temperature is 37. Here we've got the picture of her injury, and as you can see, it's really quite a nasty one. She's intruded her upper right central incisor quite badly, and it's got a gingival tear with it, of course. And she's got a fracture of the adjacent tooth. It's possible that she's also lost her upper right C. As you can see, it's partially erupted on the side there, perhaps a little bit early. Worth considering whether any of these adjacent teeth are mobile as well. So take a second, if you haven't already, and pause and think what investigations you might want for this child, and even perhaps write them down and try and come up with a list. I think in this particular instance, you would obviously want some radiographs, and we've talked about already the practicalities of getting some intraorals in A&E, but certainly an OPT wouldn't go amiss in this particular instance. She says she's lost a bit of tooth, and she says she's lost a baby tooth. And you can see that she has certainly at least lost a bit of tooth. So it's really important to find out where that is. Is it in her lip? Do we need a soft tissue radiograph? Or has she aspirated it, and do we need a chest x-ray? Particularly because she had a seizure, she might not even have any recollection of having coughed or aspirated something. which children won't always report, and neither will adults. So when you don't know where a bit of tooth is, you've really got to go digging to find out where that piece has gone. Consider the child's epilepsy. In this case, it's a known diagnosis, but is it a known diagnosis in your case? Do they need any further investigations? These further investigations aren't going to be for you to organise, but you should be satisfied that your patient has an appropriate follow-up, and that a line has been drawn under their underlying medical issue before you discharge them from the department. So we've talked about the injuries already, and again, this is just to reiterate. So she's got a severe intrusion of the upper right one, a crown fracture of her upper left one, loss of her upper right C, and a possible luxation injury of the upper right 2, given the extent of the trauma in that quadrant. Again, it might be worth just pausing here and having a think about how you would manage this case. What are you going to do with each of the individual components of the dental trauma? And what are you going to do in terms of the management overall? How would you approach it? How would you consider, say, giving the local? How would you consider managing the dental traumatic injuries that she's got? In this instance, like I mentioned, it's really important to exclude that a bit of tooth has been aspirated. In this particular case, that wasn't the case. She hadn't aspirated any fragments of tooth, but I have put a sample chest x-ray on where a fragment of tooth has been aspirated, and you can see it quite clearly there on the left of the patient's chest in the circle. Generally, the right main bronchus is the kind of offending site, as that's the straightest line that these things fall down. But it's not a hard and fast rule, and unfortunately, bits of tooth falling down airways don't always follow the rules. It's really, really important to account for missing hard tissue, because occasionally you will be surprised by the fact that there is a bit of tooth somewhere. So it's really important to exclude that it's not there, because that can pose some serious issues down the line, an aspiration, pneumonia, and an associated infection. So really important that you exclude that that's not there and that you act appropriately if it is. Again, don't really expect you to know exactly what to be done with that, but you do need to be able to highlight it to the ED staff and just ask for advice on where and when this should go and what team is appropriate to refer it to. The purpose of this case was really to prompt you to think about intrusion injuries. Intrusion injuries can be classed as mild, moderate, or severe, based on less than 3 millimeters, 3 to 6 millimeters, or greater than 6 millimeters. The easiest way to measure this is on the adjacent tooth, the CEJ of the adjacent tooth, to the CEJ of your tooth, or the tip of the adjacent tooth to the tip of the tooth in question, depending on what you can see. In our case, this child is 8 years old. It's important to consider that the child might not have a fully developed apex of their tooth. A PA radiograph is going to be needed to assess this, and again, that's difficult to get in A&E. But your initial management probably won't change as a result. So for a mild intrusion, you would manage that conservatively and monitor it for movement. For a moderate intrusion, if it's an immature apex, then you should initially monitor it and refer for orthodontic extrusion. But if it's a mature apex, then you may need to actively reposition that, either surgically if it's loose or orthodontically if it's not. It's kind of my general rule of thumb, but that's not a hard and fast rule, and it's patient specific. If it's a severe intrusion with an immature apex, that should be orthodontically extruded, and if it's a mature apex, then that should be surgically repositioned and splinted if possible. This might be something you'll struggle to do by yourself overnight, and it's probably something that can wait until the next day if you're really struggling by yourself. So I suppose hierodontics at 5 a.m. on a hospital trolley isn't something that's going to make a massive difference to a patient in A&E, whereas if you bring them back during the day, if you're unsure, that sometimes can be a better course of action. It's obviously worth noting that you won't be expected to do the orthodontic extrusion, but just make an appropriate referral in an appropriate fashion as soon as possible and let the patient know that that's the plan. And then to the management of this case. If possible, you should temporize the upper left one, as that'll be kind of sore and sensitive. Again, on a hospital trolley in A&E, it's not going to be achievable to get them a beautiful class 4 restoration, but to cover it over so that they don't have any sensitivity or discomfort is reasonable. You should assess the upper left 1 and upper right 2 teeth for mobility. And if they are luxated, you should apply a trauma splint. And it's also obviously worth thinking about, in this case, considerations for temporizing in the mixed dentition. This is really hard. This can be quite tricky to do. Bonding to primary teeth isn't as good as bonding to permanent teeth, and your splint can be quite mobile. You might have to extend your splint even, for it to become reasonably semi-rigid. As well as the splint being mobile, the teeth can be mobile, and that obviously doesn't give you much to work with in terms of stabilization. So you may have to extend your splint a bit further in order to get that nice rigidity. And if there's nothing to bond to, consider other types of splints and what might be possible. So in this case, perhaps a pull down splint might work more effectively if they've not got anything to bond to on either side. For this particular child, because she's got an intrusion injury, that might not be the most appropriate because it won't allow the tooth to come down necessarily. So it's on balance based on kind of the benefits of stabilizing the adjacent teeth and how mobile they are. But it's worth considering in a child that taking an impression and getting a pull down splint is often an option and might provide, I suppose, a better stabilization for them in the interim period. Again, this can be difficult to get overnight, depending on your unit and what's possible locally. All well and good talking about how we would ideally manage an 8-year-old child in A&E, but sometimes there can be considerations such as their behaviour to account for as well. Non-pharmacological methods of managing their behaviour can be to just create a calm environment and build a good rapport with the child. And in my experience, this is the most invaluable tool that you can use, because if you can try and get the child on board with the treatment and their compliance, you're far more likely to have success. You can also use tips and tricks like the tell, show, do technique. You can use an insulin needle to give the local anaesthetic to make it less uncomfortable. And all of these are just little things that you can do to make it more comfortable for the child, to try and help them to manage with the treatment. There is also kind of pharmacological means of management which might be available in A&E, such as nitrous oxide or ketamine sedation, depending on the unit that you work in. As well as things like topical local anaesthetic, which can provide a small difference in helping the child to cope with having a local anaesthetic. Ultimately, it may well be that you need a general anaesthetic in order to treat the child, and that's a judgment call based on how the child is behaving at the time that you want to try and treat them. It's also important to consider her medical history. So this child's got epilepsy, so leaving anything that's loose or easily dislodgeable near the airway isn't really particularly advisable. If your splint is loose and likely to fall out repeatedly, it's worth reconsidering your approach, because you don't want to leave anything in that patient's airway that if they had another seizure, they could potentially aspirate. It might also give you a lower threshold for splinting a slightly mobile tooth, or for taking out, say, a loose primary tooth that's been injured in the trauma as well, that you don't want to leave those lingering around in what might potentially be a compromised airway or an airway that's not well protected in another seizure. In terms of follow-up, it's also important to check if there's any pulpal involvement in the crown of the fractured tooth. We know the evidence tells us that if they have a sphex pulpotomy within 72 hours of trauma, that can be very effective treatment. So if you note that and you can get, pulp cap it with some dical and get them to their dentist in time, or get them to a pediatric dentist in time, you may well help them to get a mature apex on that tooth and keep the tooth in the longer run. So you lower the burden of treatment on the tooth by a very easy early intervention. So worth considering. And again, then, what follow-up are they going to have? This patient doesn't have a dentist. They're going to need to get one. Is there a pediatric unit near you that might take a referral, or a pediatric dentist who might have availability? It's really important that when we provide treatment for these children and for adults, that they have appropriate dental follow-up. And in particularly cases that have immature apices, it's worth discussion with a pediatric dentist if that's available to you, as they may well be able to follow it up with a more specialist eye. Just a quick word on trauma in the primary dentition. This is generally managed conservatively. So if the tooth is so loose that it's going to fall out, then generally you can remove that quite easily. If it's a little bit mobile, then we tend not to do anything with that. Consider if there's an airway risk, if the teeth are particularly mobile, and also consider the advice that you'll give the parents regarding the permanent teeth, as this is often their main concern. So there is the risk of dilaceration, there is the risk of enamel defects, and there is a risk of kind of delayed eruption or non-eruption of those teeth. So it's worth warning the patients the parents even at the time that these are possibilities and that they should be trying to get their child in with a dentist sooner rather than later, so that this can be tracked and followed up and caught early if it does happen. Moving on to our final case, which is case 3. This case involves a 16-year-old girl who rushes into A&E with her mum. She fainted while she was grocery shopping and knocked out her front tooth. But she only had her braces off 2 months ago, so they're really keen to find out if you can help and save this tooth. So as with the last cases, you ask for some more information, and what you find is that this girl lost consciousness whilst outside a shop and banged her face on the ground, and this happened about 2 hours ago. A passing by dentist suggested that she put the tooth in some milk, and so that's what she did. But what else would you like to know about this patient? Any other details? The details that I would want to know are: why did she lose consciousness? Was it a witness loss of consciousness? Was there a seizure activity? Does she have any known medical underlying background that might have caused it? Where's the tooth now? And was it the whole tooth? I'd want to establish an exact timeline with the patient. So maybe she fell 2 hours ago, but she found the tooth and put it in milk an hour after that. Or maybe maybe it was more like 3 hours ago. By the time I got in the ambulance, it was 2. And being quite a time sensitive thing, it's important that you pin down the exact timeline. It's really easy to focus only on the tooth in this case because we hear avulsion and we think time sensitive, but it's really important that you tease out the history and ask about any other injuries as well. So when you ask about this patient's medical history, you're told she's got type 1 diabetes and celiac disease. So she takes short and long acting insulin every day, and being 16, she probably has a reasonably good grasp on her diabetes and how she manages it. It's worth asking about her glycemic control to see how that's been. She's allergic to penicillin, and she's come in with her mum who's very worried because she's just finished her orthodontic treatment. Again, as I mentioned in the earlier case, it's always worth considering non-accidental injury in presentations of dental trauma. So these are her observations. Her oxygen saturation is 99% on room air and she's speaking in full sentences. She's got a normal respirate, heart rate and blood pressure. She is now alert and oriented and her temperature is 36.6 degrees. Her blood glucose is 11 millimoles per litre, which is to the higher end. Her blood glucose has increased from 3.6 immediately after her collapse when her mum used her glucometer to take her blood glucose to 11 since she was given a Lucozade by the shop owner who saw her passing out outside. The importance of this is that under an A to E assessment, you should always include a blood glucose as this can be a cause of loss of consciousness and a cause of somebody being acutely unwell or indeed of somebody having a low GCS. Although it's already been managed in this case and she will be having follow-up, it's really important not to miss this because that can be life-threatening. This is the examination in the case. I'm not sure an avulsion would ever actually happen so neatly, but as you can see, she's lost her upper right central incisor in the trauma. And she's brought it in some milk. She's got it in a tub on the side and it's the whole tooth which has come out intact. With these cases, there's always an element of an alveolar fracture again, because by definition to lose the tooth, you must have traumatized the alveolus that was holding it in. As with the last 2 cases, we'll take a second to think about the investigations that we would like to have. As we've mentioned before, important to exclude any head injuries and any other injuries, and whether or not she needs a CT head in order to exclude those, as well as radiographs of the mouth and face. Moving on to the treatment in this case, this is an avulsed permanent tooth, likely with a mature apex, which you'll be able to see when the tooth's in your hand before you put it back in. This is a time-dependent treatment. The sooner you can get that tooth back in, the better the chances she has of keeping that tooth there, at least for some period of time. The maturity of the root development in every case is worth considering. And this young lady was outdoors when she had her injury, so checking her tetanus status and giving her a tetanus booster if she needs is very important. So in an ideal world, the tooth will be put back in before the patient comes to the department, and that gives it its best chance. But second best is an extraoral dry time stored in a physiological medium like milk or balanced salt solution for less than an hour. So giving some local and gently rinsing the tooth, pick it up by the crown so that you don't damage the PDL. Reimplant the tooth gently back into the socket with digital pressure. Sometimes you might need to get an instrument and just check that there's kind of no clot within the socket, no loose bits of alveolar bone that need repositioning before you put it back in. And then you apply a trauma splint like we've already talked about. If the extraoral dry time is more than an hour and it's been stored in a physiological medium, then give some local and again gently rinse it with saline. You should try and remove any non-viable PDL at this point because it's not going to do any good. And consider soaking it in 2% sodium fluoride for 20 minutes. This is in the traumatology guidelines because these teeth will inevitably ankylose, and this just kind of delays that process a little bit. You should reimplant the tooth and then splint it for 4 weeks. In all avulsed, permanent and fully formed teeth, they should have the commencement of root treatment within 7 days, as the vitality of the tooth has a hopeless prognosis. Whereas a prolonged extraoral dry time, there's inevitable ankylosis. So removing the PDL and soaking it just slows that down, as I've said, but it's worth considering if this tooth is worth reimplanting. And that's a serious conversation to have with patients and parents. The burden of care that this tooth is going to incur with what is likely a hopeless prognosis, particularly if it's been dry and properly dry, not within a... So the extraoral dry time referred to in the guidelines includes being stored in a physiological medium. But if it's been stored in gauze or something, and the prognosis for that tooth is so poor that after any kind of length of time, it's worth having a discussion as to whether it's worth putting back in and whether or not they want to invest that much time and treatment into a tooth that ultimately, unfortunately, they will lose. For teeth with immature apices, if there's an extraoral dry time of less than an hour, then give some local, and the guidelines suggest soaking it in topical antibiotics, so minocycline or doxycycline for 5 minutes. This theoretically improves the chances of revascularization of the tooth. This is unlikely to be something that you'll be able to get within a reasonable time frame in A&E. It's probably not stored there, and if it is, it might take you an hour to get it. So again, this is a time-sensitive thing, and it's a balance that you've got to strike. But if it is available to you, then it's suggested in the guidelines. Then you should reimplant the tooth and splint it for 2 to 4 weeks. Their follow-up should include vitality testing because this is the one scenario in which it's possible that the tooth might regain vitality down the line. In terms of a tooth that has extraoral dry time of over an hour with incomplete apices, you should give some local, gently rinse it with saline and remove any non-viable PDL. Consider soaking it in sodium fluoride for the same reason as you would for a mature apex. Reimplant it and splint the tooth. And as with the permanent teeth that are avulsed, they require root treatment within 7 days, as the prognosis of the vitality of the tooth is hopeless. In all avulsion injuries, the guidelines recommend systemic antibiotics, although the evidence base for this is reasonably poor. Although if they've got a gingival laceration and an avulsion, then I suppose by definition it's an open fracture, which generally is accepted to require antibiotics. The traumatology guidelines suggest the first line antibiotic for this is doxycycline, and given our patient is allergic to penicillin, that's a pretty reasonable one to give. And a second line antibiotic where children under 12 should get amoxicillin. And as I mentioned already, in every case, it's worth considering whether or not this tooth is worth reimplanting and having that conversation, as the burden of care for the tooth is going to be quite large going forward. Some cases can present really late to ED, and they can present with adjacent periodontally involved teeth or missing teeth, which aren't really appropriate to splint, and the patients can also be quite medically complex. So where possible, particularly if you're not reimplanting a tooth for a child, it's often worth getting some senior advice just so that you're not taking that decision entirely by yourself. And finally, what post-op instructions and advice will you give? For an avulsed tooth, I think the most important point to reinforce is the very poor prognosis of the tooth. And I often tell patients that the best case scenario, we can hope to keep that tooth there for them in the medium term, but that ultimately it's going to need replacing. Whether or not they manage to keep that tooth in the long term, it's really important to be realistic with them about the fact that even after 2 weeks when you take the splint off, or 4 weeks when you take the splint off, that tooth might still be lost. And that's not particularly nice for them to have as a surprise if they think the tooth's been saved. A strict soft diet is really important, and no contact sports don't re-traumatize it until the splint comes off, and then to wear a gum shield after that if they haven't before. Really, really, really important is that they get the appropriate follow-up with their dentist, and that's the thing to hammer home as well, that if they don't get the appropriate follow-up, that the prognosis for any kind of a dental trauma injury is really quite poor, and they're at risk of getting infection. They need to have the splint off in an appropriate time frame, so they need to see a dentist ideally within a week in order to have appropriate intraoral x-rays taken, vitality testing and treatment planning, as well as warning avulsed teeth that they will require a root treatment within 7 days, except for an immature apex which has had less than 60 minutes extraoral dry time. That concludes the cases for this session. For some further reading, this On Call in Oral and Maxillofacial Surgery book is really helpful for all MaxFax SHO queries. It's really well laid out. It's got some very good sections on managing injuries of the face, head and neck whilst on call. The Association of Dental Traumatology guidelines are the gold standard and have been re-evaluated in the recent years. They've got really nice tables that tell you the investigations you should do, the diagnostic criteria, your initial management, the longer term management and the follow-up for these patients. So definitely worth having a look at and being up to date with. This paper from the Irish Dental Journal in 2017, Tips for Splinting Traumatized Teeth, is a really nice paper with a few different suggestions of how teeth can be best splinted and how best to approach it. So I've put the link there, and that's definitely worth looking up. And the Tooth SOS app is a really handy one to have in your pocket so that you can just pull it out and figure out what treatment you can immediately provide for a dental trauma when you encounter it in A&E. But there's loads of resources available online, and it would be impossible to provide them all. Those are just a few kind of choice ones that I quite like myself. So thank you very much for joining us for this session today. I hope you've enjoyed it, and I hope you found it useful. If you've got any questions, send them on to omfssurvivalguide@gmail.com and don't hesitate to do so, as we're always aiming to improve our sessions and improve the information that we can give you. So if you've got any questions or comments, please send them on to that email address, and we're more than happy to receive them and to reply back to you with any answers that we can. I hope you've enjoyed the session. I hope it's been informative, and I hope it helps when you start on the wards as a MaxFax DCT or SHO. So the very best of luck with it, and thank you and goodbye.